Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous series on cranial nerve examination, this is examination of 8 cranial nerve we call acoustic nerve, or we also call vestibulocochlear nerve, which has got two portion, vestibular division and cochlear division. So we'll be dealing with this particular cranial nerve, that is 8 cranial nerve. We'll be talking on those again: anatomy, function, method of examination, interpretation and localization. So we'll be dividing into two parts. It is a special sensory nerve, and being a two portion, cochlear division is for hearing while vestibular division is for balance part. So any damage to 8th cranial nerve will be producing problem with hearing, that is deafness or disturbances in hearing, which may be conductive deafness, or we call nerve conduction deafness or conductive deafness. While damage to vestibular division will produce some of the symptoms like dizziness, vertigo, nausea, vomiting, loss of balance, and also it may produce nystagmus. So we'll be dealing with that particular part. So vestibular division is for maintenance of posture, balance, and we call equilibrium, while cochlear division is for hearing portion. So it is concerned with hearing. This is concerned with maintenance of balance and posture. So we'll be talking of both those parts. But before we go to that, there is something called as an different components apart from two apparatus, that is cochlear apparatus and vestibular apparatus. We call external ear, middle ear and internal ear. External ear consists of a ear pinna and this external auditory canal. While middle ear, laterally this is tympanic membrane. Then there is a small space we call middle ear. Now this particular space is containing three bones: malleus, incus and stapes bone. And that particular cavity has got four walls: medial, not actually medial, we'll call superior, inferior, anterior and posterior. Laterally there is a tympanic membrane, and medially it is a border of inner ear, and it is connected to upper part of the pharynx by a tube called Eustachian tube. This Eustachian tube. And inner ear is a bony portion in what we call is a petrous part of temporal bone, in which you will have a two material, one cochlear portion and one we call as semicircular canal with utricle. We'll be showing you that. This is semicircular canals, three semicircular canal with a utricle parts, while this will be a cochlear portion, and this will be present in a bony portion of petrous part of temporal bone we call it the inner ear. From this, the axonal fibers will be running. This will be cochlear division, this will be vestibular division, and both combined together we call a vestibulocochlear nerve or acoustic nerve. And it will end in, being a special sensory, it will end in pontine part of midbrain. This is midbrain portion. So this is pons part. This is upper part of midbrain, pons and medulla. So it will end in pontine part of brain stem. And there will be two separate portions. Because this will be internal acoustic meatus, through which the nerve will be coming out and it will be entering into the pons. that vestibular division will end in vestibular nucleus and cochlear division will end in a cochlear nucleus. So from those particular portion, it will go and end in that particular part, then the fiber will cross to the opposite side, it will ascend up, and then it will end in a temporal lobe, which we call as the auditory area. Auditory area. And that cochlear division part will be ending in auditory area, while vestibular division will be connected to multiple different portions in a brainstem. We'll be talking regarding that part. So this is regarding auditory part, auditory pathway. This is a bipolar neuron in a cochlea, which will be ascending up. It will end in a cochlear nucleus. Cochlear nucleus. This is a cochlear nerve or cochlear part of 8th cranial nerve. So it will carry the sensation of hearing. Will go to the cochlear nucleus. From cochlear nucleus, the fiber will cross to the opposite side. It will ascend up along with the lateral lemniscus. Then it will end in a medial geniculate body, and from that medial geniculate body, via acoustic radiation, it will end in a temporal lobe. Temporal lobe. So there will be two portions. One we call as air conduction, where the sound waves from the surrounding will enter the external acoustic meatus. Then it will vibrate the tympanic membrane. There will be vibration of those three bones, malleus, incus and stapes, we call auditory ossicles. You will have a fenestra vestibuli, which is present in the inner ear, where the stapes bone will move with movement of these three bones and with the help of one muscle we call stapedius muscle, which receives the nerve supply from fascia. And you will have a movement of perilymph within the scala vestibuli. Endolymph will conduct within the cochlear duct. It will stimulate the spiral organ that will transmit those impulses to the cochlear nerve, and then finally it will end in auditory center. And we have shown you that from cochlear nerve it will end in cochlear nucleus. The fiber will cross to the opposite side. It will ascend up in a lateral lemniscus. It will end in, we have shown you in previous slide, it will end in medial geniculate body. From there you will get an acoustic radiation, and that will end into temporal lobe. So this is called conduction of the sound, air conduction. There is something called as a bone conduction also. In bone conduction, sound wave will travel by skull bones, and it will stimulate the bony labyrinth part, and directly it will stimulate the perilymph without stimulating tympanic membrane and those three bones, malleus, incus and stapes. So directly it will stimulate the perilymphatic portion, then endolymph, cochlear nerve, spiral organ, cochlear nerve, and then that will be transmitted to auditory center. So here the middle ear part, that is tympanic membrane, malleus, incus and stapes, and the movement of the foot process of stapes bone is bypassed, and directly there is a stimulation of bony labyrinth that will stimulate the perilymphatic, endolymph, spiral organs, and then cochlear nerve will transmit the impulse to the auditory center. This is called bone conduction, and that we test in while doing a Weber's test. So anything which damages the vestibular division will produce disturbances in hearing part, we call deafness, which can be conductive deafness or a nerve deafness. If there is a damage to cochlear division, it will be a nerve deafness. If there is something happening in the middle ear, it will be conductive deafness. And if there is any disorders which is producing middle ear disease, it can produce a continuous humming sound we call tinnitus. And if there is a simultaneously stimulation of the vestibular division, you will have dizziness, vertigo, nausea, vomiting, imbalance, ataxia, and nystagmus. So this will be the thing which will be happening. So along with cochlear division, if there is a vestibular division affected, then you will have these symptoms. If only cochlear division is affected, then you will have either deafness or tinnitus. And deafness can be of two groups, two varieties, conductive deafness and we call nerve deafness. So vestibular division will produce dizziness, vertigo, nausea, vomiting, imbalance, ataxia, and nystagmus. So eighth cranial nerve is a pure sensory, two parts, vestibular and cochlear. For vestibular division, we do one test that is for balance test, that is we call Romberg test and Berenice-Caleric test. While for cochlear division, we do the tuning fork test, mainly Raynaud's test, Weber's test, and sometime you can perform Wenkebeck test, etc. There are some other names also. As we go through, we'll be mentioning those. And another test which is done by a special instrument we call audiometry. So we already mentioned vestibular part. If there is a damage, you will have a nystagmus, you will have vertigo, you will have dizziness, you will have ataxia, etc. While cochlear division will produce disturbances in hearing on the affected side, and that may be two varieties. One, conductive deafness, and second, nerve deafness. Conductive deafness will be because of damage in the middle ear, while nerve deafness will be because of damage to the cochlear division, that is cochlear nerve fibers. So if that is damaged, you will have a nerve conduction damage, and if you got a middle ear damage or damage in the external auditory canal, it will be conductive deafness, or we call bone conduction and air conduction will be affected. So vestibular cochlear division, main function hearing and balance. For conductive part, or we call for cochlear division, we do Weber's test and Raynaud's test. And for reflexes of vestibular apparatus, you can perform an occulocephalic reflex like doll's eye movement, caloric test, etc. And you can go for Romberg test. So before hearing evaluation, history, physical examination, and external ear examination with eardrum should be done. So external auditory canal should be clean and clear. And then you can go for audiological analysis, that is tuning fork test. And if we find any particular defect in either Raynaud's test or Weber's test, then you can go for audiometry to find out whether it is what type of deafness and how severe it is. So before we do that auditory examination, or we call cochlear division examination, examination of ear should be done. You listen to the person, and when you are asking a question, is he finding any problem in hearing part, that should be done. So we do a non-electronic examination, that is by what we call as a tuning fork. So in that tuning fork, usually we use 128, 256, 512. So mainly very commonly we utilize 256 frequency. While for a sophisticated or we call electronic instrument like audiogram, acoustic emittance, audiometry, brainstem response, autoacoustic emission, spatial audiometry test, etc. can be done, and that is done by a ENT group of people. As far as the tuning fork test is concerned, most commonly which is being done is Raynaud's test and Weber's test. Occasionally you perform Schwaber's test or Bing test or absolute bone conduction test, etc. As far as the tuning fork is concerned, these are called prongs and this is called stem. and at the base of these prongs, the frequency is written. The most common frequency what is being utilized for the test is 256. Very rarely we require 512 frequency. Commonest we utilize 256. You have to explain the person how you do the test, and before starting a test you do external ear examination, rule out presence of any wax, foreign body, infection, or any animated material, cotton material, etc. That should be ruled out. And also look at the eardrum if you can examine that eardrum clearly by throwing a bright light. So all those conditions should be ruled out. And if any one of this is present, like wax, blood clot, foreign body, infected material, pus, we call small abscess, etc., or if there is an eardrum perforation, that will disturb your findings. While you are taking a history, when you are talking by sitting on the one side or standing on the one side, if person is finding some hearing disturbance, and when you go to the opposite side and if person is able to hear nicely, that is a very simple mechanism by which you can find out the hearing defects. Raynaud's test is based on a basic principle that air conduction is always better than bone conduction in any normal person, meaning when you strike the tuning fork, you bring it close to the ear pinna, the prongs should be perpendicular at ear pinna, so that when vibration takes place of the prongs, the sound will be transmitted to external auditory canal, tympanic membrane will vibrate, malleus incus stapes bone will vibrate, and you will have a movement of the foot of stapes which will stimulate the foramen ovale, and then you will have a stimulation of the cochlear apparatus. Impulse will be converted into an electrical impulse which will be transmitted by acoustic nerve to acoustic nucleus which is present in pons, and from that the fiber will cross to the opposite side, and that will be transmitted via lateral lemniscus to medial geniculate body, and from medial geniculate body auditory fibers will end into temporal lobe of opposite side. So this will be what we'll be able to examine. So in a normal person, when you strike the tuning fork, you bring it near the ear pinna. As soon as the person stops hearing that, if you put it on a mastoid process, person will not be able to hear, because air conduction is always better than bone conduction. And if you strike the tuning fork, you put it in the bone, that is mastoid process. When person stops hearing, bring it close to the ear pinna. Still, if the person can hear the vibrating sound, that means air conduction is better than bone conduction. In a normal person, air conduction is always better than bone conduction. So that is considered as normal. Now, if in the person on say right side, the bone conduction is better than air conduction, means on the right side, that is the middle ear disease, or we call conductive deafness, meaning either person has got some pathology in external auditory canal, or something is happening in the middle ear, that is eardrum. Either there is some pathology in middle ear like otitis media, acute or chronic otitis media, or there is something happening to the bones like you might have bone fusion, or person is having some pathophysiology even in ischiation tube, that will all produce a disturbances in bone conduction, we call as a conductive deafness. So if air conduction is better than bone conduction, it is normal. And if both are diminished, air conduction and both bone conduction are diminished, it will be very typical finding in nerve deafness. And if bone conduction is better than air conduction, means person has got some pathophysiology which is not allowing the transmission of air conduction properly. That means bone conduction becomes better than air conduction. That is indicative of middle ear disease, or we call conductive deafness. In Weber's test, after striking a tuning fork, you put it exactly in the center part of the vertex, either on the forehead or on the top of the vertex, and ask the person on which side he is able to hear better. In a normal person, bone conduction is equal on both the sides. That means the person will be able to hear equal on both the sides. If person says now he is able to hear much better on one side, so if it is lateralized to one side, that is to affected side, it indicates the middle ear disease. And if it is lateralized to the opposite side, that means the now conduction deafness on that side. Very simple to understand because Weber's test is mainly a bone conduction. So if bone conduction is better than air conduction, that will be the side where the bone conduction will be better and air conduction will not be good. So person will be able to hear much better on a Weber's test. That will be indicating of a conductive deafness on the affected side. On the side where the person is able to hear much better by Weber's test. And if the person has got lateralized to the opposite side, that means the opposite side, the person is having bone conduction better than the normal side. That is indicative of a now conduction deafness. And that will be very peculiar in a person where the person has got both air conduction and bone conduction both are diminished. And this will be Weber's test. In modified Weber's test, you close both external auditory canal. So that will make it more sensitive because now you are testing only bone conduction. Where air conduction you have stopped because you are closing both external auditory canal. So that will make it Weber's test more sensitive. So there is something called as a conductive deafness. This conductive deafness is due to the defect of the sound transmission from external ear, I already explained, to the inner ear. And that will be because of foreign body, wax, thickened tympanic membrane, damaged tympanic membrane, otitis media, maybe acute or chronic, maybe a sclerosis of ossicles, that is Malleus incus and stapes, we call otosclerosis, or even a ischiation tube block. This will be all conductive deafness. And if this happens, means person will not have air conduction better. So bone conduction will be better than air conduction. So in a conductive deafness, bone conduction will be better than air conduction. While in a nerve defects, that is nerve deafness, it is due to the damage in the internal ear where there is a damage to nervous conduction part of a cochlear division, which can be hereditary or can be because of a damage to the auditory pathway, either because of a vascular damage or because of the toxic material like say chloroquine, quinine, streptomycin, those can produce damage, or because of 8 cranial nerve tumor which is producing damage to what we call is a cochlear division. So in this condition you can have nerve deafness. And don't forget Meniere's disease. In Meniere's disease you will have a nerve conduction deafness. So drugs like streptomycin, quinine, chloroquine will produce nerve conduction deafness as well as damage to even vestibular apparatus. And Meniere's will also produce damage to both vestibular as well as cochlear division. So this will be the Raynaud's test. First, this is a bone conduction. This is a air conduction. If air conduction is better than bone conduction, normal. If bone conduction is better than air conduction, it means middle ear disease or even the disease of conductive deafness or conductive defects. And that will be very common in external auditory canal or middle ear. That is tympanic membrane, Malleus incus and stapes, where you can have otosclerosis, middle ear disease like otitis media, and external ear, otitis externa, foreign body, wax, cotton, or any insect also. So all those can produce conductive deafness. While damage to the inner ear, that is directly to the cochlear apparatus or the nerve fibers, we call cochlear nerve, it will be nerve deafness. So normal air conduction better than bone conduction. If bone conduction is better than air conduction, we say that is abnormal. We always mention that as an abnormal. So whenever bone conduction becomes better than air conduction, meaning there is a conductive deafness. There is a conductive deafness. So always remember that. And in case of nerve conduction deafness, you will have both air conduction as well as bone conduction both being diminished. So that will be typical in case of a nerve deafness. While in a Weber test, we already mentioned that because in a Weber test, you are testing mainly the bone conduction. So if it is lateralized to one side, the bone conduction is better to that side. That means bone conduction is better than air conduction on that damaged side. And if that is there, person is having a middle ear disease, or we call conductive deafness. So that will be peculiar. So by and large, it is put on a forehead or on a vertex. Either you put on the vertex or on the forehead. And to make it more sensitive, you can close the external auditory canal. In Weber test, we confirm the deafness which is detected by Raynaud's test or Squab's test. So Weber test is to confirm the bone conduction. So it is put in the center part of the skull, either on the vertex or on the forehead. Forehead is always better than vertex. So by and large, we put it on the forehead, and that will be very, very useful. You can utilize 512 frequency in Weber's test. So in a conductive deafness, it will be positive on the side of the damage, while in sensory, it will be to the opposite side. Sensory loss, it will be to the opposite side. So this is how you mention that Weber test is lateralized on which side. Say it is lateralized to the right. So either there is a conductive deafness on the right, or there is a nerve deafness on opposite side. So depending upon that, you try to mention. So midline Weber's test, normal, bilateral equal, symmetrical. If it is lateralized to the good ear, that means sensory defects, or we call nerve defect. Lateralized to the bad ear, conductive deafness, that is typical. So if the person has got ear discharge, say on the right ear, and if it is lateralized to the right side, that means right side conductive deafness. And if both ears, external auditory canal and middle ear, are normal, and if it is lateralized to the good ear, then that means bad ear has got sensory defects. So Raynaud's test, we already mentioned, normal, air conduction better than bone conduction. If bone conduction is better than air conduction, we call negative. That is very typical in conductive deafness. And when it is negative and Weber's test is to the opposite side, that means neuronal defects. While Weber test, if you put it in the center, both side is equal, normal. If it is localized to the opposite side, it is mainly because of the sensory nerve defects. And if it is lateralized to the same side, it is a conductive defect. Remember this, the findings and interpretation of Raynaud's test and Weber's test. Very simple to understand. Squab's test is same like Raynaud's test. Hardly there is any difference. It is again a comparison of bone conduction to the bone conduction of yourself. So we compare the bone conduction of a normal person to a bone conduction of the person in whom you are doing a checking. That is called Squab's test. Interpretation remains on the bone conduction, that is indirectly it will be same like what we call as Weber's test. But only difference is you are comparing with your own bone conduction. There is one more test. So absolute bone conduction is like Squab's test only. So either you label as an absolute bone conduction test or Squab's test. While Bing test is again determination of the conductive loss by putting a tuning fork on a mastoid process. So you are putting on a mastoid process and you are repeating the test. That will be Bing test. And when you are comparing with the person examiner, that is called Squab's test or absolute bone conduction test. Mainly remember Raynaud's test and Weber test. These are all the sophisticated tests done by an instrument we call audiograms. That we call is a routine audiometry, which is mainly for air conduction threshold, what you are examining. So different types of audiometry you can do. You can do the bone conduction threshold and you can do air conduction threshold. So two types of things can be done in an audiometry, and you can find out the amount of damage and the type of defects. Then you can do the speech discrimination classification depending upon the different results, mild, moderate and poor. Then you can do acoustic emittance audiometry. I am not aware of all these detailed procedures. This is just out of way we are mentioning in this particular lecture. So this is one method of examining by sophisticated instrument we call acoustic emittance audiometry. Then there is acoustic impedance audiometry, where we tympanometry, acoustic reflex threshold test and acoustic reflex decay etc. can be done. All this, if you want, if you are interested, you can go through the YouTubes etc. I am not expert in this field. Then there is a tympanometry, reflex threshold test, reflex decay test etc. Then there is one called as a auto acoustic emission test, which is mainly done for inner ear. So these are the different instruments which are being there, and you can do auto acoustic emission test. Then there is audio auditory brainstem response. You can look for this. So auditory brainstem response, these are the different type of instruments, and you try to find out is there any defect. Particularly the person will have a deafness very frequently, either because of disease of external ear or middle ear or eustachian tube, or even because of the prolonged exposure to the loud sound also can produce a damage. And in old age, very frequently because of Meniere's person can develop, or even because of uh, degeneration of nerve fibers. In CNS disease like meningitis, demyelinating disease, or because of drug induced, particularly streptomycin, chloroquine, quinine, etc. So those drugs can produce a damage. You can have a conductive deafness very frequently, we have already mentioned, wax in the external ear or foreign body, or even insect, chronic otitis media, acute otitis media, cholesteatoma, eardrum damage. Then we call as autosclerosis of bones, otitis externa, otitis, otitis externa, autosclerosis can produce conductive deafness. And we have already mentioned you can have a neuronal deafness because of the viral infection, damage, presbycusis. Then drugs like aminoglycoside, furosemide, quinine, meningitis, Meniere's disease, loud sound, or even in case of a fractured temporal bone, petrous part of temporal bone, if there is a fracture, you can have damage. So this will be all multiple different types, even including neurofibroma, Alport syndromes. These are genetic disorders. Demyelinating disease, particularly multiple sclerosis. So now we go to what we call as a vestibular division. Now that vestibular division, from vestibular ganglia, the fiber will go to the vestibular nucleus. From there, some of the fiber will be connected to medial longitudinal fascicles and connecting to third, fourth and sixth cranial nerve, and that will be responsible for nystagmus. Some fiber are connecting to cerebellum, which will be responsible for impulse going to the cerebellum and will help in maintenance of balance and equilibrium. And fiber will cross to the opposite side along with medial lemniscus. It will end in what we call as the cerebral cortex via thalamus, and that will be giving an input to cerebral cortex, and which will be further connected to basal ganglia as well as cerebellum, and which will take part in maintenance of posture, equilibrium and balance. So that will be the function of vestibular system in short. So vestibular system will be connected to cerebellum, to third, fourth and sixth cranial nerve, to cerebral cortex, basal ganglia, some of the descending tracts, that is vestibulospinal tracts, tectospinal tract, rubrospinal tracts, etc. which will take part in maintenance of tone, posture and equilibrium. It is also connected to the 3, 4 and 6 cranial nerve, and also via vestibulo-reticular tracts. It will be taking part in occulocephalic reflexes. So whenever there is a damage to these vestibular connections and vestibular apparatus, it can give rise to nystagmus because of that connection to the 3, 4 and 6 cranial nerve. Because of connection to the cerebellum, it will take part in imbalance, because if there is a damage, balance is disturbed, so person will have ataxia. And because it is connected to nucleus ambiguous, it will also produce little nausea and vomiting, and that is a quite common symptom whenever there is a stimulation of vestibular apparatus or vestibular nucleus. These are some of the things which will be there. These are some we call as some of the tracts. I am not going into detail. These are descending tracts via cerebellum, via inferior peduncle. Then it is connected to vestibulospinal tracts, vestibulo-reticular tracts, etc. So because of all this connection, it is taking part in all those different components. So whenever there is a damage, person will have a dizziness, vertigo. So vestibular division will produce vertigo, dizziness, ataxia, imbalance, and stimulation of 3rd, 4th and 6th cranial nerve will produce nystagmus because of occulocephalic reflexes. So person will have very commonly dizziness, nystagmus, imbalance, nausea, vomiting. Quite common because of a disturbances in vestibular apparatus. And with this person will have imbalance, we call that as ataxia. So for that there is one test called rotation test. Nowadays very rarely being done, but a simple test. You ask the person to sit on a revolving chair and you rotate very fast and stop suddenly. In normal person also, the person will develop little nystagmus, vertigo and vomiting. But in a person without even a stimulus, if a person is having nystagmus, he is having vertigo and he is having vomiting, indicates the peripheral apparatus is being stimulated. You can do the another test, that is caloric test. By and large, it is very useful in an unconscious person to find out occulocephalic reflexes. We always remember cows, cold, opposite side we call as a fast component, and warm material, that is hot fluids or hot water, to the same side. So when you give a stimulus by putting either a cold water or a warm water, you get a fast component and a slow component. Indirectly, if nystagmus is stimulated, it indicates that vestibular apparatus is intact, pons is intact. Then most important test, which is very easy, that is we call Romberg test. Now in that Romberg test, person is asked to stand with two legs together, eye closed, and always stand on the back side of the person so that he doesn't get a fall. And if he falls, you can give the support. He is supposed to stand with the two legs together, two arms by the side and eye closed. A normal person will be able to maintain the balance. Say this is two legs together, two arms by the side and eye closed. Person will be able to stand with the feet together and eye closed. Now if a person sways, that means Romberg test positive. Now when he is able to stand with the feet together and eye open, now ask the person to close the eye. And if a person starts swaying, that means Romberg test is positive. This indicates that three possibilities. One, cerebellar damage, vestibular apparatus damage, and we call sensory ataxia. These three conditions. So Romberg test will be positive in all these three conditions. So in case of sensory ataxia, now very simple, just follow this properly. Now because of no impulse can travel from the both lower limbs. So this input is not going to cerebellum. You are closing the eye. So second input is not going. Now person starts getting ataxia, or we call Romberg test is positive. Now if a person keeps eye open and if a person is able to stand properly, what he does, he will usually do two legs separate. So he will be using wide base. He will be widening the two arms so to increase the area of balance, and he keeps the eye open and he can maintain. But as soon as he closes the eye and if he gets fall, it is classical of sensory ataxia. Means the second input to the cerebellum is stopped. Now person gets ataxia. If he keeps the eye open, he can maintain the balance by widening the two legs, means separating the two legs and widening the arms. So he increases the area of gravity. So that will be classical sensory ataxia. While in cerebellum, with eye open or with eye closed, it will remain same. So if a person has got Romberg test positive, whether with eye open or with eye closed, it will be cerebellar ataxia. And if a person is able to maintain the balance with eye open and with eye closed, he starts having Romberg test positive, it will be sensory ataxia. So this is a simple way of differentiating sensory from cerebellum by doing Romberg test. And you can see here, modified Romberg test, you are asking the person to stand with little extension of the neck and you are holding. In vestibular ataxia, this is sensory ataxia. In sensory ataxia, you just tap, the person will have fall. While in vestibular ataxia, the person will not fall. So you leave this arm. In sensory, person will have a fall. While in vestibular, the person will not have a fall. So this will be in difference in modified Romberg test. There is one maneuver which is done mainly for BPPV, that is called Dick's Halpic maneuver, which will be positive for BPPV, benign postural paroxysmal vertigo. There is an occulocephalic reflexes we call as a Berenice caloric test. So if you add a cold water and if there is a nystagmus in a normal person, you will have a tonic reflex, that is the fast component going towards the side, and in a person in whom you get asymmetrical response, that means the caloric test is negative. This will be interpreting that there is a damage to the vestibular apparatus or there is a damage to the pons. This reflexes elicitation is very helpful in an unconscious individual. Here you are using a cold water or a hot water. Always remember, the cold water will give a fast component to the opposite side, slow component to the side, and in a doll's eye movement, you lift the upper eyelid and then rotate the head. If you get nystagmus, that means the doll's eye movement is present. That indicates the vestibular apparatus is working and pons is able to give you oculocephalic reflexes. If doll's eye movement is absent and caloric test is negative, it indicates the damage to either the vestibular apparatus or to the pons, that is vestibular nucleus. That will be the importance. So vestibulo-ocular reflexes you can go for, and that will be helping you to identify the damage to the vestibular apparatus or damage at the level of pons. So you can do a caloric test or you can do a doll's eye movement. So at your leisure time, you can go through this diagram. So usually cold, opposite side, warm, same side. So usually it is a fast component and a slow component. Forget about, if you don't remember, forget about that. Remember that if you can elicit the reflex, that means vestibular apparatus is working. So usually it is said that no fast component in coma, brainstem, if it is intact, you will be able to elicit the caloric reflex if there is no damage to vestibular apparatus or no damage to brainstem. So it is very important in a person with unconsciousness. It is very, very helpful. So usually it is helpful in an unconscious individual, and you can do it with a cold water or a warm water. So this is just an explanation. I'm just skipping this part. So if it is elicitable, not elicitable, depending upon that, you mention that whether the vestibular apparatus is damaged or not damaged, because this is one variety of oculocephalic reflex. So very simple, when you add a cold water, you can see the eye is moving to the same side, and when you add here, it is moving to this side. Warm water, it is to the opposite side. So instead of that, if the warm water is producing movement to the same side, that means that side vestibular apparatus is damaged. Same with cold water. Normal person, eye will move towards the side of stimulus in a cold water. But if there is a damage, if it moves to the opposite side, you will say that caloric test is negative because the opposite eye will be producing a stimulus. I am not going into detail regarding the pathway, etc. That is mentioned here. That is, if you want to go through here, everything is being mentioned. If you are interested in what are the pathway, these two diagrams. This is vestibulo-ocular reflexes, and that we utilized in a caloric test. Same, this is Dolce movement and ocular reflexes. Together it is put, this is a Dolce movement and this is a vestibular ocular reflexes. That is we call cold water and warm water. So summary in that. And this is Dolce movement. What are the different components? What are the different pathways? So you go with a Dolce movement or you'd go with a caloric test. So this is a Dolce movement. This is oculocephalic reflexes. This is a difference between central and peripheral damage. At your leisure time, you can go through. That is, we call damage to the brainstem, and this is damage to the vestibular apparatus in inner ear. What will be the finding? These are the different tests. Acoustic reflex testing. Definitely, she doesn't have what we call as a balance problem. So I end my lecture here. Thank you all. Thank you all for taking out time. I know that your time is valuable and I appreciate that you have spent some of the time with me. If you like this lecture, don't forget to press button like and subscribe, and you can share with your friends. I feel that this lecture will be helpful because good number of time in oral, Raynaud's test, Weber's test, Dolce movement, caloric test are very frequently being asked. So those will be very, very important. And you remember there are two components, vestibular component and cochlear component. In both the tests are different. Romberg test can be very frequently asked as a short note. So hope for the best. See you in next lecture.